Hello everyone. Today we are going to see some diseases in dermatology lecture. Without further delay, let's get started. What about the Fabry's disease? The Fabry's disease is due to alpha galactosidase A deficiency. This alpha galactosidase A is a X-linked recessive lysosomal storage disorder. Because of deficient alpha galactosidase, there is buildup of ceramide trihexoside with this characteristic skin lesions. What are they? They are the angiokeratomas, that is dilated capillaries forming the papules like this. In addition to it, they do present with renal complications, cardiac complications, but this is the characteristic angiokeratomas that you see in Fabry's disease. They can give you a picture like this and then ask you for the diagnosis. The vignette will also present with some details like a 6-month-old male presenting with a classic triad of findings with fibrous tissue, with bone replaced by fibrous tissue, or it's a precocious puberty with enlarged testes, and all these details can be given. So this picture is typical of coast of Maine, that is cafe au lait spots picture. There is irregular jagged borders distinguishing it from a neurofibromatosis. So here what is this even though it looks like cafe au lait spots, this is known as coast of Maine because this is similar to, so see, this is the real coast of Maine. So this is an island in states with ragged borders. This is the Atlantic Ocean. So the clinical picture is similar to this. That is a coast of Maine appearance. This triad, in McCune-Albright syndrome, we have cafe au lait spots in this typical coast of Maine appearance, along with polyostotic fibrous dysplasia as well as precocious puberty. What about hyper IgE syndrome? The hyper IgE syndrome is also known as Job syndrome. It has a constellation of symptoms. The very best mnemonic to remember is FATED, that is fated. Facies, of course, facies. A stands for abscess, staphylococcal abscess. T stands for retained primary teeth. E stands for hyper IgE. Hyper IgE antibodies are in excess, and D stands for characteristic dermatological abnormalities. So like eczema. The clinical presentation, the vignette can give you details like the 3-year-old male with retained primary teeth, eczema, and recurrent staphylococcal abscess without typical inflammation. So this points towards Job syndrome or hyper IgE syndrome. Let's see about leukocyte adhesion deficiency. What is this? In leukocyte adhesion deficiency, for the neutrophils to migrate to the site of infection or inflammation, it needs to get adhered, rolled, and then migrate to the site of infection. Say for example, the skin, the neutrophils are supposed to fight against the infection. How will it go? It will first adhere, it will roll, and then it will penetrate the blood vessel and then reach the skin tissue. I'm just giving you an overall idea. So if it is unable to adhere, if the leukocyte or the neutrophils are unable to adhere, then it results in a deficiency known as leukocyte adhesion deficiency. Here there is defective LFA1 CD18 integrin, which will prevent the neutrophil adhesion as well as migration to the infection sites. This is in particular seen in leukocyte adhesion deficiency. So what are the characteristics? There will be absent neutrophils. When the biopsy is done and at the infection sites, then the biopsy will show absent neutrophils or decreased neutrophils at the infection sites. What about the skin infections? There will be infection without any pus formation because the pus per se is leukocytes, right? So there can be infection but without any pus formation. In addition to it, there will be delayed umbilical cord separation. Why? This is an early sign in neonatal period. For the umbilical cord to get separated, it needs the leukocyte adhesion, that the leukocyte adhesion or the leukocytes which are concentrated in that area will cause umbilical cord separation. So delayed umbilical cord separation will result, so this is one of the symptoms of leukocyte adhesion deficiency. What is this? They can give you a picture like this and then they can ask you what is the next step. So this is the Mongolian spot. We should not mistake it for child abuse. What is a Mongolian spot? A Mongolian spot is here. This is exactly a Mongolian spot, but why does it occur? The melanocytes, they are present in the dermis. They are supposed to migrate superficially to the stratum basale of the epidermis during development. When that doesn't migrate to the stratum basale, it will result in Mongolian spots. It is a benign birthmark and with age it will disappear. Acanthosis nigricans. I will show you the real picture in the next slide. In Acanthosis nigricans, this is how the Acanthosis nigricans will be. This is the neck picture. So, what is the reason for Acanthosis nigricans? The first reason is insulin resistance. The second, not very common, but the second reason also is visceral malignancies. So, hyperpigmented plaques are pathognomic for insulin resistance as well as visceral malignancy. Here you see this is another picture, and they can ask you the diagnosis or what is the next step to confirm the diagnosis. Here their details can be like they present with lantern jaw, increased hat shoe size, and hypertension. This picture per se is a skin tag which you will be seeing in acromegaly. So acromegaly people present with lantern jaw, increased hat and shoe size, as well as hypertension, diabetes mellitus, right? Now the question tests you even further. What is the diagnostic test to determine acromegaly? I am supposed to measure, it is a growth hormone exists, but we are not going to measure growth hormone. We are supposed to measure insulin like growth factor 1, because growth hormone will stimulate the liver to produce insulin like growth factor 1, which is the diagnostic key to diagnose acromegaly. So here you see a typical ear defect, and they can ask you what is the other associated feature. Ear defect is mostly seen in charge syndrome. C stands for coloboma of the iris, H stands for heart defects, A stands for atresia of the choana, R stands for retardation of growth, G stands for genitourinary anomalies, and E stands for ear anomalies. So they can give you some symptoms, and then they can ask you what is missing or what can be prone to develop in later. So any combination of those can be given. What is this? This is a preauricular pit. Here, a 7-year-old male with bilateral holes anterior to the ears are seen, and they are asymptomatic. What is the treatment? For preauricular pit, there is no treatment necessary for asymptomatic. But if it becomes infected, then surgical closure is indicated. This picture can be given and they can ask you to diagnose. This is a strawberry hemangioma. It appears as a small red mark. There will be spontaneous resolution within 2 to 3 years. But during the early phase, that is during the initial phase, there can be rapid enlargement in the first months. So benign capillary growth tumor in neonates showing the characteristic growth pattern is a strawberry hemangioma. Unless there is any issue, we need not interfere it, then that undergoes a spontaneous regression too. This picture, this can be given. This looks exactly like cherry, right? And that looks like a strawberry. So this is known as a cherry hemangioma. So what is the etiology? UV light exposure will result in, this is also a benign, similar to the previous one, but this can occur because of UV light exposure. It has an increased prevalence with advancing age. Similar to strawberry hemangioma, cherry hemangioma also doesn't need any treatment. Here I want to tell you about spina bifida occulta. The spina bifida occulta is a neonate with a tuft of hair on the lower back overlying the vertebral defect. There is a hair tuft or a dimple over the lumbosacral spine. Incomplete neural tube closure without the neural tube exposure. The spina rhizophysium can also be used as a term for to indicate spina bifida. What about Cushing syndrome? Cushing syndrome, we know that it occurs due to exogenous corticosteroids. Chronic prednisolone for autoimmune diseases can result in Cushing's. So chronic prednisolone will result in terminal collagen and capillary wall breakdown. Microbleeding into skin creates a classic appearance of the striae which we see in Cushing syndrome. So the vignette will be like 50-year-old male with ulcerative colitis on chronic prednisolone, and what is that we see? That is a purple striae and it is a Cushing syndrome. So because of Cushing syndrome, we not only have purple striae but also we have hyperpigmentation because of the presence of alpha melanocyte stimulating hormone, that is MSH, which are responsible, the melanocytes which are responsible for the dark pigmentation. The small cell lung cancer can also cause ectopic ACTH secretion, which can result in a Cushing syndrome as well as a hyperpigmentation. So this is a tricky question which I want you to know. See, a 41-year-old male with the glucose of 130 milligram per deciliter and a hand pain with the Hebden nodes and forearm skin darkening. So if you see here with the Hebden nodes, what are Hebden nodes? Hebden nodes are those that are found in the distal interphalangeal joints. So we know that any abnormality, that is when there is a nodules in the distal interphalangeal joint, then that means it is osteoarthritis. But here, even though they have hand pain with the Hebden nodes, it doesn't denote it does not, the entire vignette doesn't fit in with the osteoarthritis because they have glucose of 130 milligram. Why would osteoarthritis present with the glucose 130 milligram, and why would they have forearm skin darkening? So therefore these constellation of symptoms fit into hereditary hemochromatosis. The glucose of 130 milligram, that is, it presents with diabetes. Why? Because in hereditary hemochromatosis the excess of the iron gets deposited in the pancreas and the pancreas is not able to secrete insulin, therefore it is resulting in hyperglycemia. Why would they have hand pain with Hebden nodes? That is also seen in hereditary hemochromatosis because it presents with the calcium chondrocalcinosis and all that is also seen in hereditary hemochromatosis because of the iron overload. I will explain it in detail to you. What about forearm skin darkening? That is because of the deposition of the iron in the skin. So that is known as the bronze diabetes. So here in this patient, what is the next step? The next step, we need to suspect that it is a hereditary hemochromatosis, and the next diagnostic step should be check serum ferritin. Elevated levels will confirm iron overload. The hereditary hemochromatosis will present with the pseudo gout arthritis. They will be presenting with arthritis. In addition to it, they will be presenting with the pseudo gout. What is the difference between pseudo gout and the normal gout? Normal gout, we have monosodium urate crystal deposition, but in pseudo gout there is calcium pyrophosphate deposition. So I have separate videos on gout and the pseudo gout and all the differences and much more. But this is in short for hereditary hemochromatosis and to solve this vignette. Addison's disease. What is Addison's disease? Addison's disease is a primary hypoadrenalism. What does it mean? It means that the adrenals are not secreting properly because of any reason. But since it is a primary hypoadrenalism, the reason has to be in the adrenals. So whatever be the reason, the pathology is in the adrenal, right? So here the vignette will be a 30-year-old male with a 6-month history of fatigue. Why would they have fatigue? The adrenals are not secreting properly and therefore they feel fatigue. Electrolyte abnormalities, because the adrenals are not secreting and therefore there is no mineralocorticoids. The glucocorticoids are also not properly been secreted, so therefore it was resulting in a subsequent electrolyte abnormalities. Eosinophilia. We do have eosinophilia. Why? Because the glucocorticoids which are secreted by the adrenal glands are necessary for the eosinophilic sequestration. So when the glucocorticoids are not secreted properly, then the eosinophils are not sequestered and they are not destroyed. Therefore, there is an increased amount of eosinophils, so resulting in eosinophilia as well as a hyperpigmentation. Obviously, because the adrenals are not getting secreted, therefore the ACTH is increasing so as to because there is no negative feedback and the ACTH is increasing to make the adrenals to secrete more. So when the ACTH is increasing, it will also be releasing the melanocyte. It will also be stimulating the melanocyte stimulating hormone, and it produces and the MSH is produced in excess. Therefore, they will be presenting with a hyperpigmentation. So how will the patient be? The patient will be presenting with a hyponatremia because we don't have a mineralocorticoid. So mineralocorticoids are those which will cause sodium absorption and potassium excretion. So sodium is not absorbed, resulting in hyponatremia. Potassium is not excreted, resulting in hyperkalemia. And eosinophils, as I told you, it is because of cortisol deficiency. Here, the one point I want you to know this: when Addison's disease, it is supposed mostly mainly targeted in the adrenals, and it results in a deficiency of the mineralocorticoids. But it doesn't stop there. There is associated deficiency of glucocorticoids too. So that is the concept you need to know. So how will you test a Addison's disease? ACTH stimulation test can be done, which will help us to diagnose Addison's. This picture can be given and they can ask you to diagnose. The vignette can say additional details like neonate with violaceous leg lesion and a platelet count of 50,000. What is it? This violaceous leg lesions and a platelet count of only 50,000. So this large vascular lesion has sequestered all the platelets and it is resulting in a thrombocytopenia. The platelet sequestration within the hemangioma is what happens in the Kasabach Meritt syndrome. So this violaceous lesions is responsible for the deficiency of the platelets. What is the treatment? Surgical intervention is required. It looks as if the surgical intervention we need not have to do, but unfortunately surgical intervention is the treatment for Kasabach Meritt syndrome. So here this is not a strawberry hemangioma. You shouldn't confuse this. Strawberry hemangioma will typically be almost resemble a strawberry, and for that if it is asymptomatic we need not have to do any treatment. But Kasabach Meritt syndrome, since it is presenting with the low platelets because of sequestration of platelets within the lesions, we do have to operate it. So what is the uh, that's it, we have come to the end of the presentation. So with this I have a good news for you. My name is Dr. Veena. I am a medical doctor. I am an anesthesiologist. So teaching is my passion, and I love to see young doctors do very well in theory as well as in practicals. If you like my teaching, if you like my slides, and if you want to get mentored by me, whether you are a medical graduate or someone who is preparing for MLE exams, I am more than happy to guide you. You can send me a message in the comments, and I am looking forward to see you succeed. Have a good day. All the best for your exams.